All right, good morning. On behalf of the Florida Department of Health and Volusia County, welcome. Welcome to the 2021 Path for Hope Virtual Summit. My name is Helena Gerard, and I will be the facilitator for this session. You have joined the session titled, The Need to Do More for Mothers. This session is being recorded, and all participants will be muted during the session. There will be question and answer time at the end of the session for you to pose questions. And you may raise your hand using the reaction button at the bottom of your screen. And we will then call on you and allow you to speak or unmute yourself and speak. You may also submit your questions during the presentation in the chat box, and we will pose them to Dr. Sappenfield at the end of the session if time allows. If you're requesting CEUs for this session, please indicate your presence by responding to the pop-up in mid-session. We'll have a poll pop up mid-session. Thank you to the Path for Hope Summit Planning Committee partners, Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and the Volusia Recovery Alliance. It is my pleasure to introduce Dr. William Sappenfield. He is the professor and director of the Child Center at the College of Public Health, University of South Florida. He also serves as director of the Florida Perinatal Quality Collaborative, or FPQC, a statewide multi-organizational effort to improve health and healthcare quality of mothers and infants. As both a pediatrician and an epidemiologist, Dr. Sappenfield has 36 years of experience in epidemiological and public health research, teaching and practice in maternal and child health at a community, state, and national level. As a nationally recognized leader in the field of maternal and child health epidemiology, Dr. Sappenfield spent his first 22 years of his career as a CDC medical epidemiologist working with the state and local public health agencies to enhance their capacity to use epidemiology, evaluation, and research to improve the health of women and children. Upon retiring from the CDC, Dr. Sappenfield served 6 years at the Florida Department of Health as the state MCH epidemiologist and as unit director for the MCH Practice and Analysis Unit, guiding policies and programs for Florida mothers and children at a state and community level. In recent years, Dr. Sappenfield was one of the leaders who developed the FPQC. The FPQC's collaborative quality improvement efforts include reducing the rate of non-medically indicated early term deliveries, managing maternal hemorrhage at delivery, treating maternal hypertension, promoting use on mother's own milk in the ICU, reducing primary cesareans, promoting access to immediate postpartum use of LARC, and improving the health care of mothers with opioid use disorder and their babies. Maternal mortality and its prevention have been a major focus of Dr. Sappenfield's throughout his career. And I do want to add that I've gotten to work with him over the last few years, and it has been such a pleasure and an honor. And I'm so grateful that we've gotten to know each other in different capacities, and you've played an incredible role in my recovery. So I just want to thank you and welcome you. And without any further ado, I will turn it over to you. Thank you.
Thank you, Lena. It's been a pleasure to work with you, and it's a pleasure to be here today. I want to talk to you about how women in Florida need more. And what I'm going to do is I'm going to start out by hearing from some of our moms and sharing a video.
I was afraid of so many things when I came to this hospital. I was afraid DCF was going to be called. I was afraid they were going to take my baby. I was afraid that I was going to go to jail. I was afraid they were going to rip me away from my life and send me to treatment far away.
So 6 years ago, I went to the hospital to have my daughter, Raina. I had substance use disorder. The staff knew that I tested positive for substances. I was afraid that they were going to take away my baby. They called DCF. DCF did come and they did take my baby out of custody. So from that point, I had to engage in services. I went to drug court, and drug court at the time I thought was the worst and most uncomfortable thing that I'd ever done in my life, but it turned out to be the thing that saved my life.
Taking the first step is definitely the hardest. Asking for help, that's the ripping off of the Band-Aid. And everything after that is the healing pain.
Once I realized that I needed the help that they were giving me, I had an opportunity to focus on myself and become the mom that I wanted to be.
It's painful. It's not easy. Nobody ever said it was easy, but it's doable, and there's hope.
It was actually the wake-up call that I needed. It was the only opportunity I was going to have to actually seek the help that I needed, because I didn't know how to ask for help, and I actually needed that thing to happen so that I had the opportunity to actually engage in help.
Eventually had a doctor say that she believed in me and saw potential.
But there was this one nurse,
and I trusted her enough to tell her that I was using drugs.
That at one point told me, I know you're going to be a great mom.
And we worked together.
And I held on to that because that was the first time I actually felt hopeful.
And 6 years later, we're still friends. It takes a lot of hope.
If any of this sounds familiar to you, give yourself a break, give yourself a chance. There's help out there if you need it.
I hope you all enjoyed that. In that, sorry. So I thought we'd start there because it's always good to hear from the mothers first, and it's always important to hear why these mothers need more. And so I'm now going to go ahead and start the talk. I'm hoping that you all can see my slides. So the need to do more for mothers. I just start out with disclosure statements. I have no relevant financial relationships with manufacturers of any commercial products or providers of commercial services. And I do not intend to discuss any unimproved investigative use or commercial products or anything like that. And the whole learning objectives for this sessions are going to be, I want you to learn more about our MORE initiative, learn about the progress that we've had during times with COVID and the real struggles there, and then hear more about our lessons learned. It's very important if we just start out with a big picture, and you may have already heard this in some of the other presentations, but where do we fit in opioids? The USA now currently represents about only 4.3% of the world's population, but it covers 66% of the illegal drug use, 80% of the global supply of opioid, and about 99% of the global supply of hydrocodones. And we currently, right now, from the last year we have good data, is about 137 Americans die literally every day of opioid drug overdose. And NAS really matters, whether it's called neonatal absence syndrome or neonatal opioid withdrawal syndrome. These are babies who go through withdrawal because they were exposed to opioids while they were in the mother's womb. And it really matters to Americans. Right now in the US, latest data available, about a half a prescription of opioid is given out per American, per number of people in this country. So we still give out a huge proportion of opioid prescriptions. 1 in 3 Americans actually know somebody who was addicted to these painkillers. so that it's a common problem that everyone's aware of. And what's sad is we have all this opioid treatment over the last decade, but we have really no change in the amount of pain that people reported. This whole idea that this would help remove pain is not clear. And lastly, about 28% of privately insured women filled out at least one opioid prescription during pregnancy. So we're actually continuing to give this drug to pregnant women, given all the issues that they may have. Is NAS, though, also matters to pregnant women. Opioid withdrawal, 18 minutes. And in Florida, it's about every 7 hours that we have one. And not only does it affect our babies, it impacts our mothers. Our leading cause of death to a mother during pregnancy or up to a year afterwards is a drug-related death. We have more women during pregnancy and afterwards who die of drugs than motor vehicle accidents, suicide, and homicides. If we take all the medical reasons and all the complications of pregnancy and that end up causing women to die, there's more women dying of drug-related deaths. The current data we have goes through 2019, and we have evidence that that mortality rate during this COVID pandemic has only gone up. And so that we will see an even higher rate of deaths due to drugs. This NAS not only matters mom, but it matters because of what happens to the infant. Of those infants who have NAS, about 55 to 94% will experience some sort of sign or symptom. Almost half or more will require some medication in the hospital to help them deal with their withdrawal. It's more common among males. It's more common among babies who are born low birth weight. But they also have other medical issues. These babies not only suffer from the opioid, but it increases their risk of jaundice, respiratory complications, increases the risk of sepsis and infections, and it causes feeding problems. So this exposure causes a lot of issues to the baby. But most importantly, is it really leads to consequences later. These babies who are born with NAS or opioid withdrawal syndrome are more likely to have abuse and neglect, more likely to die of sudden infant death or shaken baby syndrome, more likely to have adverse neurological developmental outcomes and learning problems. They're more likely to be rehospitalized after birth. And drug misuse is the most common reason for a child to be removed from the home in the United States. So the consequences to the baby in this situation are large. But it should also matter to healthcare providers because we're seeing more of this. This is the prevalence of NAS in Florida. It was very, very low in 1998. It started out about 2.8. We went up into the 60 per 10,000 births, and now we're at about 56%. So it's a little bit less than 1% of our babies are born with this situation, which is quite prevalent. It should matter to our hospitals and agencies. Right now, NAS really can occupy almost 3 to 4% of the beds in the NICU here in the United States. So our healthcare providers have to deal with this issue on a daily basis. And where do we stand with NAS as a state compared to other places? We're right in the middle. We're in that royal blue stage between 5.5 and 7.6. But we are one of the higher prevalent states in the Southeast, along with Louisiana. And the reason why we're at this level is many states' rates are continuing to increase, and ours are now slowly starting to decrease, which is a good sign. This NAS causes a tremendous healthcare burden. We have increased antenatal drug use, increased incidence of NAS, increased healthcare expenditures, and increased infant disabilities. So it also means we need to have more public health measures to address this. We need to reduce exposure of this to mothers while they're pregnant or before they're pregnant. We need to actually figure out and do a better job of managing the babies. We've known that if we manage them better, we can keep them with less drugs in the hospital less and have them have better infant outcomes. And really what's most important is we need to help get these women into medication-assisted treatment and or behavioral health so that we can actually meet the problem itself, because the problem doesn't stop at delivery. 2/3 of the babies go home with the mother who's using opioid. And so that drug use continuing over the infant period will have adverse effects on that infant's development. So these are the areas where we in the FPQC, the Florida Perinatal Quality Collaborative, have been trying to address. So NAS should be mattering to all of us because it impacts all of us. It impacts your pocketbook at a minimum. It impacts the people that you know, and it impacts the future of our children. The Florida Perinatal Quality Collaborative is now 11 years old. We are a statewide partnership trying to improve the health care of mothers and babies near the time of delivery. We are currently working with 84 of the state's 110 maternity hospitals to improve the care. Our vision is that all of Florida's mothers, infants, and families will have the best health outcomes possible through receiving respectful, equitable, high quality, evidence-based perinatal care. We're a voluntary organization. We are data-driven, evidence-based. We are population-based. We want to cover all babies. We are equity centered, trying to to provide equity for all. And then we want to be a value add to the family, a value add to our healthcare providers, and value add to our partners. What we do is we do a series of quality initiatives. We're getting ready to start our 6th round. We have indicators. We work on training of data. We've worked on infant issues, working on maternal issues. And one of those issues is called MORE, our maternal opioid recovery effort. Our focus are moms. We work with hospitals, and we're all designed to include hospitals and families all in the quality work that we do to improve the best of care. Again, we couldn't do what we do without our partners. The collaborative, in fact, was formed because the partners said we needed to have one, and they established it and they put it in at the Child Center at USF, and they've now been our predominantly our funders. Right now, the Centers for Disease Control, the Centers for the Florida Department of Health, and ACOG through the AIM Alliance are our 3 primary funders. We love the name of our initiative, MORE, Maternal Opioid Recovery Effort, because we know these women need more attention, more support, more services, more follow-up, and more compassion. And we could not do this without all of our partners. This map on the left that you see is of the state and where the prevalence of NAS occurs in the state. And you can see that it occurs along the Northeast and across to the west coast of Florida, down near the Gulf. The colors are the prevalence. The round dots are the numbers of babies who are born in those time periods. And as you can see on the right, these are where our MORE hospitals are. And they basically are where a lot of the large blue dots are. These are the hospitals who are dealing with the most numbers of babies. The reason you see 21 plus 12 is we started this initiative right before COVID. We had 23 hospitals. 21 are stayed with us, and then we expanded the initiative to include a few more just recently. And so we're now up to 33 hospitals. And this covers close to half of the NAS babies born in the state. The idea of quality improvement is to identify areas where you can improve the quality of care. You do that through what we call primary drivers, things that you need to do that improve care. And our primary drivers here are screening. We want to identify women and all their different issues that they may have. We want to work on some prevention. We want to get them into treatment. We need to get them into comprehensive discharge planning so we can get them into a supportive system of care and the policies and procedures that need to go with it. Now, our outcome is the challenge because the deaths are few and not a good way at a hospital level to monitor quality. And so what we really decided is we want roughly half of the women to receive the optimal care that's evidence-based that they should be receiving while they're in the hospital. And that is an aggressive goal because these women are complex and need a lot of services and support. Now, a normal initiative for us, we'd develop our toolkit, we'd recruit hospitals, we'd do a kickoff to get hospitals started. They would be doing changes in quality work over a time period. The project would end, and then we do a sustainability to try and keep it. Well, we did our kickoff in November, and then as you know, in February and March, COVID hit. And it caused a massive disruption in our community, but also within our hospitals. Many of our hospitals actually went on a pause. They stayed in communication with us or went to calls, but they really didn't do much work, or some actually had to stop totally and completely. And only now are some of those hospitals re-engaging in our work and more. Thanks to our funders in the Department of Health and our steering committee, we've now decided to extend the project in and not do sustainability and recruit more hospitals. So we're now trying to, over these next 9 months, trying to give a strong effort to really improving the quality of the care for these mothers. We, in this effort, put out an urgent maternal mortality message. Florida has a high maternal mortality rate. It's a little bit higher than the nation or around the rate of the nation as a whole. But what we wanted to do is we wanted to point out to our OB providers and hospitals that drug-related deaths are the leading cause of death, and that 75% of these deaths occur after the mother has left the hospital after giving birth. So in other words, we know who these women are. We generally know that they have a substance abuse disorder, and that we're not getting them in a system of care that's supportive that can prevent these deaths. Opioid use, whenever it is a chronic issue, it is treatable, and these deaths are highly preventable. And we've used this to try and encourage our doctors and hospitals to step up, that we need to do a better job of taking care of the mothers when we encounter them. How do we do that? What does that look like? How does an organization like FPQC improve quality? Well, for the first thing we do is we make it easy for hospitals. We put everything that they need together, short of doing the work. So for example, we have a team care plan. We have a checklist that goes through all the evidence-based things that needs to happen with that mother while she's in the hospital, not when the baby's in the hospital, but while she's in the hospital and before she goes home. So this checklist makes it easy for you to know what to do. And we put that in a folder, and along with it on one side is patient education material. We work with the Healthy Start Coalition of Hillsborough, and we have a booklet for the mom that says everything they need to know about substance abuse disorder during pregnancy, about what's happening to them, what's happening to the baby, what do they need to expect, and what can they do. And we provide other key education material for them. And on the other side, we put in provider education material just to remind the provider exactly what they need to do, but what they need to know, that these women are frequently have been traumatized and need trauma-informed care. And how do they screen? And how do they train people to use naloxone? And what does their treatment algorithm look like? And so we put this all in a folder. And the reason we do that is these babies don't occur often. We said in the state, it's 1 every 7 hours. But no matter what day, no matter what hour, if a nurse screens and finds a mother has a substance abuse disorder, they can pull this folder out and assure that the mother can get the best of quality care any place. And so we try to work hard in helping our hospitals do that. You saw one of our videos, Getting Real. We do a lot of these mini videos that people can use in their staff, our doctors' meetings. We also do hour-long trainings where we can teach you how to do trauma-informed care and motivational interviewing, and how do you treat someone with opioid use, and why do people use opioid? And all those are there to help educate the hospital. And it's all actually on for free on our website and readily available not only to our participating hospitals, but to anyone else who'd like access. So we basically, why would anyone want to participate with us? We, as I said, put it all together for you. So we offer monthly coaching calls so that you can learn what works and what doesn't work from fellow hospitals. We have collaborative wide meetings where we educate and motivate the whole group. We have educational videos I showed. We provide rapid data reporting. So you know each month, are you improving on the care you're providing? Or are you not? Where are you? Where do you need to focus? Where do you need to do better? We constantly send them updates on the best of care and what the issues are. We provide customized consultation and presentations and technical assistance. We have a fabulous online toolkit that's available to anyone. And then with this initiative, we've been working hard on community engagement. For example, we've been pulling in our Healthy Starts, trying to do community resource directories for our hospitals and starting to communicate better about how to make referrals for these moms. So does what we do with the FPQC and what hospitals do, does it really improve quality of care? Well, that first primary driver I mentioned to you is screening. That green line that you see in front of you is the percentage of all, not just select women, all pregnant women who are screened for substance abuse disorders. We only had 14 hospitals with COVID. We're getting more and more hospitals to start reporting now. We hope to get everyone up. But they started out with only about 60% being screened, and now we're over 95% of all women being screened for substance abuse disorders. About half these women are known to have mental health issues at the same time with their substance abuse. And we have almost over 95% being screened now for mental health issues. A large percentage of women have intermittent partner violence. They are screening for that. And the last one is infectious diseases. These women get exposed to a lot of different diseases. One of the latest ones has been hepatitis C. And so we're working with our hospitals that while we have them, that we can look and find all the medical issues that these mothers may be having so that we can send them home with the baby in the best of health. On the prevention side, many of these women do not want to get pregnant again soon, or maybe not even get pregnant again at all. And so we have been working with our hospitals to do a better job of educating and counseling on contraception if mothers want to and what type they want. And as you can see, the percentage of women who are getting counseling is actually going up. We started in the 50% range, and we're now up to about 65 to 66%. And so we're making this a more intentional process. The treatment side is the hard side. Ideally, we would love to have all these women identified during their pregnancy. So even before they're in the hospital, they're in a community system of care that's providing behavioral health and medically assisted treatment and other support services that they need, medical services that they need. Right now, we are not doing well at that. Only about, of all those women of opioid exposure, only about 31% are actually getting into MAT. Now, some of that is they may not need full medicated assisted treatment. They're only using opioids recreationally, but they probably need behavioral health. But our system of care doesn't quite know, doesn't have the bandwidth to deal with all opioid use exposure. And so not all these women get into care during pregnancy. Only about 4% get in and get started during hospitalization. And so we spend a lot of time trying to get them into referral. Women who die, the best way to prevent women from dying after they leave the hospital is to get them into a medication-assisted treatment program and to get them access to naloxone. And that leads us to the next piece, that comprehensive discharge piece. We need to get women more naloxone, and it's not something our hospitals are used to doing. They need to educate the mom about it. They need a prescription, and even better, if they can send the mom home with a naloxone for her or a loved one to be able to use if needed. The other issue I mentioned is behavioral health or medication-assisted referral. And as you can see, we are up to about 2/3. We're now down. We're down some with this COVID piece, and we need to get our referrals back up. The good news is most of these are getting social work consultation, and we know that some of that lack of referral may be that they are not in our current system eligible or appropriate for medication-assisted treatment or behavioral health. We get, again, you call the contraceptive planning. We do well at getting them into pediatrics. We are all here. Yeah, and it's still on this call. And then the Healthy Start referral, we've been getting that back up after our COVID period. So these comprehensive pieces are a lot of work for our hospitals to do, but it's something that's very important because we get to see them in the hospital because they happen to deliver. But to intervene and change the lives, we need to get these women into a supportive, comprehensive system of care. Now, one of the things we discovered is why aren't we identifying these women more prenatally? Why are we having more problems with our obstetrical providers treating these women? And so during the COVID, we had time to do some planning. We partnered with the Florida Department of Health, and we formed some listening groups. And we had 3 different physician listening groups, so very diverse groups across the state. And we asked them, what are the greatest barriers and challenges to screening or treating pregnant women with opioid? Number 1 is they really didn't feel like they were being reimbursed for the amount of time and care that these women needed. These women are extremely complex and take a lot of brain power and time, and frequently are out of the scope of services. All the docs said none of them were ever trained on how to take care of substance abusing mothers during pregnancy. And so they're out of their comfort zone. They're out of where they feel safe at practicing. It's a major issue. I mentioned that they need multiple referrals, and it's not easy to get these women on referrals because over 80% of these mothers are on Medicaid with 14 different Medicaid plans, all of which that they've got to work through. And they can't find the specialist they need depending on the plan that they're in, or they've got to go through a lot of different steps to get approvals to get them to those specialists. They say it basically takes too much time to coordinate the care that these women need. One of our practices estimated it takes them on average about an hour and a half to get these women into all the different care and services that they need. And they're just not reimbursed at that rate. And the last thing they're really worried about is if they're one of the few obstetrical providers in their community that take these women, they'll become the drug practice and they will lose all their other patients. So there's a lot of issues that we found. And so during this time period of COVID, we also got together with our partners, the health department, FPQC. I convened a couple of different work groups to work on this issue of how do we create a coordinated, enhanced system of care and do some problem solving, because we can't improve the quality of care without improving the system of care. And we've had great support from all of our state partners. ACA and Medicaid have moved now to having automatic approvals, so that you don't need to get approval to get into behavioral health or approval to get onto certain medication and a treatment. They've worked on now training and reimbursement for the OB docs. So they are now reimbursed to screen and reimbursed to do some brief intervention. And they're now setting up a referral line to the health plans case managers so that they can call and have those case managers help set up a lot of those referrals and other services that are needed and not necessarily take up the doctor and the doctor's office time. Medicaid's trying to go out of their way to make this a seamless service. And in parallel, the Department of Children and Families is responsible for those mothers who are uninsured. And so they have trying to do a case management referral process for the uninsured women, trying to do a resource guide for them to make sure that those women can get the care they need. They're providing these women priority access and making sure that they're the most important of those getting substance abuse treatment. And the latest thing that we're really excited about is they're able to provide naloxone kits for free and not-for-profit hospitals. So again, the mothers don't have to go home with a prescription, but they can literally go home with an opioid, with the naloxone right in their hands to address opioid overdose. Now, it's not easy. It's a complicated system, and hospitals have to work through a variety of pieces. And the good news is partners are still trying to work on how to make that more easy, because we know these women need to have naloxone based off the number of deaths that we're experiencing. Department of Health works on data monitoring, reporting. They're doing a lot about promoting education, like you're seeing in this workshop that's going on now. And they're also promoting the behavioral health impact. It's a grant that they have where they provide doctors and hospitals consultation services for mental health and opioid use, so that if they feel uncomfortable with a patient or situation or need more training and skill, they can call up and get within 24 hours a response from an OB who is trained in psychiatry and addiction medicine. So they have a really strong consultation program. Florida Hospital Association is there really talking about what the needs the hospitals have, but they also have been helping to recruit hospitals to participate. And they've been a conduit to us to educate all those hospitals not participating, so that all this information and all these opportunities are shared with everyone. So I mentioned our Healthy Start communities have already worked on community resource directories and trying to get referrals. And besides for all this quality work that FPQC is doing, one of the leads that we're taking is trying to provide opioid training for our OB and family practice practitioners, both those in training and those out there, because that's one of the big issues. They feel like they don't have adequate training. It's all this work is in progress and will take time, but we are trying to make the system of care better as well as improve the quality. So what lessons learned have we had? The more we dig into this, the more we learn that these mothers and babies and families really need more. This is an opportunity for change. Many of these women want to change from their substance abuse, and this is the ample opportunity to create that, but they need help in almost every dimension, from housing to food to healthcare to help with the children, as well as medication and other pieces. And so I need a supportive system. As everybody has had, COVID pandemic has caused problems in our hospitals and has really distracted people from the QI work. We're having more women die of drug overdose. We're having problems getting women into the systems of care they need. And we look forward for the pandemic to be calming down and to go to our whatever the new normal may be. I think we've also really learned that opioid use disorder is a recognized treatable chronic disease, and we can do a better job not only preventing these maternal deaths, but having better maternal and infant outcomes. We can really improve their health and well-being through a quality system of care. And to improve our healthcare quality, we need to improve our health system. We cannot do one without the other. And so we've been spending a lot of time working on those system pieces that I shared with you. Most moms with opioid use are complex and they need comprehensive care. The care for these mothers in the hospital and community is a team sport. This is really important. No one, not the nurse, not the doctor, not the social worker, not the consultants. It's going to take all of us together to make this system work for moms. In fact, many of our community services are discovering that they need to come into the hospital in order to connect these women into the community before they go home, because once they go home, they may lose them. So we need to figure out how to integrate and coordinate our care. Helping mothers to get behavioral health treatment is an issue. Women trying to even get appointments for MAT, get an OB provider is a major challenge in this state. And we need to find a way to make it easier for women when they want help to be able to get the help they need. And the last is nothing seems simple. We knew we could give out free naloxone kits, but every time you try to do something, you discover all the different other things that need to happen. So all these things take time and effort and work together. Questions? I'll turn this. I guess I'll turn the slides off for now. Comments, questions?
We do have a couple questions in the, thank you very much also. Does your hospital offer mental health services?
Good question. I'm not in a hospital. I actually work in an academic an academic institution. In fact, we tried not to be involved in patient care so that we can be independent and working with all of our hospitals. But not all hospitals have in-house mental health or in-house behavioral health treatment. And so it really depends on where you are as to what's available. The key gets to be is we need to have it available in some format. We are excited that the health department is providing the behavioral health impact program so that if you don't know how to do that or where to connect or how to handle these situations, you can get support in your hospital to try and learn how to do that and do that better. But mental health and drug abuse treatment is helpful. And I know in many states, not here, they actually start behavioral health and medication-assisted treatment while moms are even in the hospital. We are not at that stage yet. Many states are now actually using buprenorphine in OB practices, and we're not at that state yet here in Florida either. So there are areas where we could grow and improve.
There we go. Thank you. There's another, Janice Hawkins put her information. She would like to learn more about partnering with FPQC. So I can send that to you in an email.
That'd be great. The easiest thing you can do is you can send us an email at fpqc.usf.edu. That's our email address, and we can see it. If you want to learn more about us and connecting, you can also go simply to www.fpqc.org, and you can see all of our MORE initiative and all the pieces. So we're easy to connect to. And I saw somebody asked about stigma and stigma training. We do try to offer a little bit of stigma training. We try to offer it in a variety of ways. Everything from talking about stigma to the opposite, which is talking about how do we provide trauma-informed care? How do we learn how to not only not be stigmatized, but how do we learn to help the mothers and families? Because many of these mothers come from abusive situations or hostile situations or unsafe or uncomfortable situations. And so they have issues that have gone on in their life. And we as healthcare providers and as social workers and others need to learn how to approach these women in a way that is helpful and not making them worse off after they communicate. We are working with DOH. I know they've been talking about some anti-stigma campaign on a larger level. And I think all of us recognize this is a major issue. And it's really an issue if your healthcare providers are stigmatized, because you have the chance to really intervene and make a difference in these women's life, and you have every ability to shut them down.
Do you mind repeating the email address one more time so I can type it into the chat?
Why don't I just put that in the box real quick?
Oh, you're the best. Thank you. And if anybody would like to ask questions out loud, you can also raise your hand and we'll call on you.
I saw there were other questions.
Ingrid asked for contact info in the chat, and in the anti-stigma programs in your area. I think that was what you just answered. We have a thank you. Thank you. I'm in OD2A Duval County. Do we have any more questions? Comments? Anybody want to share?
I do want to give a shout out to Volusia County. Your Healthy Start, Helena, and others have done so much to help us with our MORE initiative. You all have helped us to be more community-based in guiding what we do. One of your OBs is one of our major advisors to our program. We could not do what we're doing now without all the help and support that you all have offered us. And formally, again, want to thank Helena. You saw her in the video and so much that she's done for us, but also many of the players there in the county. You guys are a stellar place.
We definitely have an amazing county. Thank you. And thank you for always supporting us. Definitely being so willing. As soon as I asked if you'd present, absolutely. It's amazing. So thank you. All right. Any more questions? Feel free. Will this webinar be available to access offline? Yes, it will be recorded and you'll be able to see it offline.
I tend to talk fast, so I may actually give you a little bit longer break, which I know with video conferences is a nice thing to have. So
Yes, absolutely. Okay, well, thank you so much, Dr. Sappenfield, for sharing your expertise. It's been amazing. The attendees, you can use the link in the chat to complete the evaluation survey for this session. Thank you to Florida State University for managing the summit evaluations. And if you have requested CEUs, we have a different survey that is SurveyMonkey that is not Florida State. And you must complete that survey to answer the question for your CEU. Thank you all for attending this session. And if you'll go to your summit program PDF or the link in the chat, you can hop in your next session, and we will now end this meeting. Thank you again so much, Dr. Sappenfield.
thank you for the invitation and best wishes.
You too. Thank you.